Good afternoon, everyone. I think as we draw to the end of the program, we move from a malignant condition to something that could be a benign malignancy, and that's endometriosis, as we all know. Why postmenopausal endometriosis as a separate entity? Yes, we are recognizing more and more of this nowadays as a separate entity, so we need to know a little bit more about how it behaves. So look at this 49-year-old, had a menopause 14 months ago. She comes to you with severe pelvic pain while she's passing motion. Ultrasound shows a right ovarian cyst 3.4 to 3.1 with complex echoes. So yes, immediately we start talking about whether it's a malignancy. We don't give importance to the pelvic pain or the painful defecation. We are now 14 months post-menopause, thinking only in terms of a malignancy. So we probably will be referring them for all the biomarkers, etc. But we have to start thinking about endometriosis after the menopause. Evaluation of the condition, whether we can give this woman symptomatic relief, how certain can we be of the diagnosis, and whether surgery can be offered or not, what sort of follow-up should we be giving her. But we've always thought of endometriosis as a condition which lives on hormones basically. So it's a premenopausal women who have endometriosis. How come after menopause? So it could be women who have had endometriosis earlier, who probably did not undergo a laparoscopy at all, who had some symptoms of pelvic pain, but it was never diagnosed. The disease actually could progress later on, even after the menopause, due to certain conditions. She may have had a laparoscopy earlier where it was not detected. It could actually come up now after menopause. We all know it's a steroid-dependent lesion, which actually experiences regression or supposed to experience regression after the menopause. So women who have endometriosis-related symptoms after natural or even a surgical menopause, women with a history of endometriosis who may experience worsening of their symptoms, they could also have a reactivation of residual disease. The use of hormone therapies, which we know is popular again now, which is meant to relieve the symptoms of menopause, could actually activate postmenopausal endometriosis. So MHT is known to stimulate the growth of endometriosis. Estrogen-only therapies and the combined MHT, where you have the combination treatment. Postmenopausal women who are not on MHT also have been shown to have this disease when they come to us with symptoms. So, is it a result of some extra ovarian estrogen production? We are all well aware of this well after the menopause as well. Does the lesion itself have a specific production of estrogen due to some kind of a local overexpression of the aromatase and other steroidogenic genes and proteins? Maybe yes. So we need to know more about it and study more about this. Only then can we actually get to the bottom of why postmenopausal endometriosis occurs. Is it a continuation of previous disease? Is it a recurrence? Or, as I said earlier, could it be a de novo condition as well? Estrogen threshold, that is, every tissue has an estrogen threshold. Every tissue which has receptivity for estrogen has a threshold. So when a certain estrogen level is reached or surpassed in these postmenopausal patients, it activates undetected or even transient foci of endometriosis. So we have to be careful when we are exposing these women to estrogen therapy. Endometriosis can persist in the presence of low circulating levels of estrogen as well. So you don't have to have the reproductive age group levels of estrogen that are normally required. It's in the postmenopausal period, fortunately, it is less common, present in very small volumes. It's less active as well. That is very important for us. It has the same immunochemical profile as in the premenopausal women. Therefore, the potential to reactivate when given the appropriate stimulation. So appropriate stimulation in the form of estrogens. Higher circulating levels or estrogenic activity is normally seen in a postmenopausal woman when we give her MHT. When she's on tamoxifen after treatment for breast cancer, food sources which we inadvertently take, which contain estrogen and estrogen-like activity, Very, very, very important to keep phytoestrogens in mind, because phytoestrogens are taken indiscriminately and we do not know the estrogen activity of these. So we need to keep this in mind also when for reactivation of endometriosis. And the density of estrogen receptors in the endometriotic tissue appears to be unchanged in the older patients. So given a stimulus, it will just start growing again. It may potentially increase the risk of any neoplastic transformation also of the residual tissue. And that is our main worry in the postmenopausal period. Important to follow up all patients who are operated for endometriosis who have been subsequently prescribed MHT on a long-term basis. So we can't just say take it short-term, don't come back for treatment or follow up later. There's very limited data on the effect of MHT in women with previous endometriosis. We all believe that tibolone is a very good option because it has all estrogenic, progesterogenic, androgenic activity, so it will suppress even if there's any endometriosis. And even in premature surgical menopause, we actually are very happy giving tibolone. So we need to also put a question mark next to it next time we think of prescribing tibolone. So unopposed estrogen therapy was found to reactivate symptoms of pelvic pain and deep dyspareunia even after a TAHBSO. So MHT immediately after hysterectomy or 6 weeks after surgery did not change the risk of recurrent pain. Again, this is a dilemma which all of us have, isn't it? Should we give a gap of 3 months and then start? Should we start immediately? Phytoestrogens, I've already said this. Over-the-counter drugs use is extremely indiscriminate. So please, please be careful because it can actually perpetuate pre-existing premenopausal endometriosis. So how can we diagnose these conditions? It's a disease with a delayed diagnosis naturally because none of us are thinking of postmenopausal endometriosis. So lack of non-invasive tools for any kind of early stage diagnosis. And there is always this long-standing myth that it will not come in the postmenopausal period. Commonest lesion, like the premenopausal women, is the ovarian tissue. And it's about 79.2% of cases actually occur only in the ovary. So laparoscopy, again, without doubt, whatever the age group, is the gold standard. Non-invasive testing is being recommended, but no particular imaging method is superior to the other. When we are thinking of deep infiltrating endometriosis, sometimes an MRI is very, very useful because ultrasound may or may not be able to pick it up. And small endometrial implants, very difficult to be picked up with any kind of imaging. So when we're talking of deep infiltrating endometriosis, then we need to use all modalities, and certain important tests are being advocated nowadays, but not in common clinical use. So the important thing in our mind is that, like the complex cyst that I told you in this woman who was 14 months postmenopausal, is it a malignancy or is it endometriosis? So the risk factors are similar to both. Laparoscopy and biopsy of the suspicious lesion can be done irrespective of age. So you need to simultaneously see and treat. So when you're doing a laparoscopy, you should be able to treat as well if your frozen section comes back as a malignancy. There are no serum markers or tests which are available for reliable diagnosis in these patients. MRI and ultrasound are very important. The interpretation is difficult in the menopausal women because we need to have a higher suspicion of neoplasm, and we all do that, and we probably tend to err more on the side of neoplasm. I recently had this lady who had a nice small, what looked like a very simple cyst with maybe a few echoes inside, no solid areas, no septations, put in a laparoscope, just flip the ovary over, frank malignancy, which was not picked up on the MRI or the ultrasound. Then we had to go for a full staging laparotomy. So the first-line investigations, which we know, the ultrasound, etc., it's transvaginal ultrasound, which can actually pick up a lot of information if used in the right hands. And it's an established method for adnexal masses. We have a lot of models on which we can try to predict the possibility of a malignancy in this. Endometriomas have very distinct characteristics on ultrasound. Actually, mostly unilocular cysts. They have this ground glass appearance, which can be very characteristically made out. And the role in assessing the disease which is involving the bladder or rectum, again, not very useful. CT MRI certainly scores over ultrasound, definitely, because it is not observer dependent. The interpretation is what is important here. So you have bowel endometriomas in the presence of colonic distension, may be made out, genitourinary tract involvement, and hydronephrosis or hydroureter can also be made out. MRI will give us an idea of non-invasive diagnostic method for DIE especially. It's very, very useful. But it's a limited indication in the diagnosis of other endometriosis. So adnexal mass, etc., any day a well-done TVS will be better. Other things like involvement of the ureter and all, basically you'll have to combine a good ultrasound with CT MRI. So this is for the DIE, sonovaginography. There are two methods. Either you use saline solution or you use a gel infusion. So you actually, it's a new diagnostic method that is being used nowadays, not widely used. And the double contrast, actually you put this dye inside the vagina and then you try to use it as an interface when you're doing the ultrasound. So hopefully it will delineate the deep infiltrating endometriosis because it will form an interface between the transducer and the lesion. The double contrast barium enema also is being increasingly used nowadays, so we need to take help from our radiology colleagues. Laparoscopy, all of us know, is the gold standard, but evaluation for chronic pelvic pain, again, has been found poor correlation with symptoms and extent of disease. In endometriosis itself, we know that there is poor correlation between symptoms and extent of disease. So when we're talking of diagnosis, it is even more so. So detected laparoscopically endometriosis in 70% of fertile asymptomatic multiparous women in whom a previous diagnosis of endometriosis has not been made based on either symptoms or investigation. So if we have a high clinical suspicion and we look for it, definitely we will be finding more and more of postmenopausal endometriosis. We also have extrapelvic endometriosis in the gastrointestinal tract and in the urinary system. So sigmoid colon followed by rectum, ileum, appendix, cecum, etc. We are seeing more and more of postmenopausal endometriosis. More rare locations are the gallbladder, Meckel's diverticulum, stomach, and endometriotic cysts of the pancreas and liver has also been described in literature. The bladder and urethral endometriosis, again, more common because this is the immediate neighbor and therefore the infiltration and involvement is definitely going to be more. So how do we treat these postmenopausal endometriosis? Initially, it was the very first reported actually way back in 1950, so that is long, long time ago. So the primary method of treatment is surgical. Medical treatment may be like an option for the follow-on or the future. So GnRH analogs, danazol, progesterone, all have found to be ineffective in treatment of postmenopausal endometriosis. In the future, aromatase inhibitors may be a new promising method because it's been found to actually improve symptoms. So as a first-line treatment when surgery is contraindicated or as a second-line treatment for recurrences following surgical treatment. So aromatase inhibitors are slowly being introduced. But of course, we know the side effect. It will significantly impair the bone mineral density and increase the rate of bone fracture. So we need to balance the two, the same problem which we would have even in the premenopausal women. And supplementation with bisphosphonate therapy is an option when you want to use aromatase inhibitors. So how do we follow up these people? Endometriosis is confirmed on investigation. Careful follow-up on a long-term basis for any future adverse outcomes. So all the things that have been listed in the follow-up, we need to keep it in mind. And long-term follow-up is important because as I will be telling you, there is a chance of malignant transformation in these tumors as well. Especially when you have obesity, unopposed estrogen are two major risk factors. And we know that obesity is a risk factor again in this age group. The BMI of most of the postmenopausal women is high. And you can actually go for a combined hormone therapy in spite of the endometriosis. We know, but then always remember, unopposed is totally contraindicated. So risk of any extra ovarian malignant transformation is very low. The most common site is the vagina. So this possible transformation, we know, we have been speaking about this in premenopausal women as well. But in pre-existing disease, once they attain menopause, the chances of you picking up something, a malignancy, is something you have to keep in mind. It does not mean that the chances are more, But we have to keep this in mind and not just say it is endometriosis. Dissemination in the ovaries, bowel, even the lungs has been described. So transformation rate is something in the ovary especially, but between 2 or 3%, which is actually not a very low figure. So in our minds, we need to make this paradigm shift from the belief that endometriosis only affects women in their reproductive age group. So that we have to remove from our mind first. Premenarchal, postmenopausal patients also can have endometriosis. Premenarchal endometriosis, people are talking of now quite a lot. Despite the low incidence, physicians should consider endometriosis in cases of unclear pelvic pain in the postmenopausal women, even if the patient has no prior history of endometriosis. So it is not a must. They need not have had endometriosis diagnosed before the menopause. And postmenopausal endometriosis exposes the patient to a higher risk of malignant transformation. So again, a very, very, very heightened clinical alert or a suspicion has to always be there. So the main message here is that this is a condition that is there, does exist. We are encountering this more and more nowadays, and we need to have a clinical suspicion. Unless we look for it, we're just going to dismiss it or probably even offer medical treatment for these people because we're not worried about any other long-term effects. Fertility is not an issue in these people. So we have to give that little extra care for postmenopausal endometriosis. Thank you very much.